if I do a quick kind of sensory motor test for upper extremity, lower extremity, for more spine stuff. So does this feel equal right to left? Yeah. Equal right to left, equal right to left, and medial, and then lateral, or you can do electron, and then you do all 3 fingers. You can go equal right to left, equal right to left, equal right to left, and you can even argue you can do radial, peripheral radial nerve back here. Equal right to left. Good. And then you can do strength. Make an okay sign. Don't let me pull it out. Good. Bring your fingers apart. Don't let me squeeze them in together. Good. And get this and keep your wrists up. Don't move your arms. Don't let me pull down. Good. Now go down. Don't let me pull up. Good. I'm gonna go like this, like we're gonna arm wrestle. Don't let me push. Don't let me pull up. Good. Arms out like a chicken wing. Good. Don't let me push down. Good. So that kind of goes through your quick test of upper. So then to do the deep tendon, I'm trying to show you this way. I go all awkward. We'll see if we can. But brachioradialis, just right in there. For biceps, remember you want them relaxed, so that little thing how you can kind of hold them here. I use my thumb. I palpate the biceps tendon. If you're not sure if you're on it, go ahead and flex against me, like we're arm wrestling again. Good, and relax. And you can palpate it and you can find it. And then I'm actually percussing on, and I can feel her arm moving. I don't know if you guys can see it, but I can definitely feel it moving. And then for triceps, just go ahead and relax. Make sure loosey-goosey. Good. So she's got some nice upper extremity tendons. You can also, if you're concerned for more central even, you can also do what's called a Hoffman. Go ahead and relax, and you're kind of flicking the third DIP, and I'm looking for thumb extension or movement of the thumb, which would be positive Hoffman. So then the same thing for a lower extremity. Does this feel equal right to left? Here, equal right to left, and I'm going, making sure I'm going medially and lateral, both sides, equal. Here she's up on one side. So I'm getting L3, 4, 5, and then can you feel me tissue here? Yeah. And then either lateral or inferior as well. Make sure you're getting S1. That feels equal right to left. Good. So now we're going to go through motor. Point your toes up to the sky. Don't just your toes. Don't let me push them down. You're going with your great toes. Good. Now cock your ankles up. Don't let me push your ankles down. Good. And hold your legs right about here. Don't let me push back. Don't let me pull forward. Good. Push your knees out against my hands. Back in together. Good. One leg at a time. I want you to pick it up off the table and up off the table. Good. And relax. So, and then we were, so that's kind of your quick motor, and when we were talking about the straight leg raise, how sometimes you kind of have to sneak it in. Okay, now I'm going to check your Achilles reflexes here. You can see I'm doing a straight leg raise on her. It's a seated straight leg raise, but if I have concern about my patient, it's a way to kind of hide it in there. And then, so you're doing your Achilles, everything you're doing it bilaterally, so you can kind of compare it. Your reflexes, your colors, the least one. All right. And then you can also do clonus. And clonus is pretty, I mean, it's a pretty sudden, I kind of just make sure they're relaxed, and it's a pretty significant dorsiflexion. It's kind of a sudden, strong dorsiflexion, and you have to hold it. You can't just do that and then, okay, I did it, I'm done. You have to hold it, and you have to wait to feel for any beats of clonus. And if you get 1 or 2 beats of clonus, that's not as concerning. If you get sustained clonus and look at your whole picture, are they here, are there valid bladder changes, or different things like that, then you would be a little bit more concerned. But that's kind of a quick rundown. You'll get much more in-depth neuro, but kind of a musculoskeletal version of a spine exam. So you've got your sensation, your motor, and your reflexes. Okay. So now, so make sure as you're doing these exams that you are getting a good lateral picture as well. So I'm going to assess her kind of interior to her, but then especially when you're talking about lordotic curves, I'm looking lateral as well. I see a nice lordotic curve, cervical and lumbar. Thoracic should be kyphotic. So I'm noting inspection can go a long way. Even if you have them exposed properly, even just the examining their scapulas, you can almost kind of, I don't know if you're just because your shirts are different, do you have scoliosis? Okay. But you can look for things like scoliosis just by, even when they're sitting and not bent over. Sometimes inspection can go a long way. Then go ahead and stand up for me. We're going to do range of motion. And then, again, be careful in doing this motion. You don't want to do it on everybody, but go ahead and bend your toes forward. Go ahead, bend over forward like you're going to touch your toes. Forward flexion, that's good. Go ahead and relax. And then lean back towards me. Good. And you're right here kind of spotting your patient. Now stand up straight. Now, again, make sure for rotation that you're fixing. Go ahead, kind of turn your upper body, turn your shoulders right and left. Good. And the other way. So that motion is coming from her lumbar spine and not coming from anywhere else. And then special test, you can go ahead and sit back down. So remember the lateral frame and where those nerve roots come out, my goal is kind of put her in this provocative position where I'm going to make that opening much smaller. So you're going to kind of look towards me and look up and let your head kind of fall towards me a little bit. And she's kind of in this position and I'm going to compress axial, and then I would ask, do you have any sensation, or they would tell you that they have pain down that arm. Yeah, it's not, yeah. Some of these tests are not the most comfortable things because you are trying to recreate the pain, and sometimes you even just have to explain to your patients that I'm not trying to hurt you, I'm just trying to get some information so we know how to get you better, okay? And sometimes just that little explanation can go a long way. Oh, lumbar spine, oh, we already did that, sorry. Oh, so I skipped the cervical part. Okay, so you go ahead and flex down, extend back up, and then rotating, it would be turn and look at this wall, turn and look at the other wall, and then come back to center, and then ear to your shoulder, ear to your other shoulder. Good, okay, so that's, sorry, that was range of motion for the cervical spine. And then lumbar we already did, and then you would just add lateral bend that sometimes you do, and I would just say bend like you're gonna grab something off the floor. So, sorry. So we talked upstairs, go ahead and stand up again. I just want to point this out. If I'm going to palpate, I can feel the top of her iliac crest right here. So that tells me that's L4-5 right there, roughly, okay? Sometimes people have little dimples right here in their skin. That's about L5-S1. So those are kind of your obvious landmarks that you would see for that. So what special tests do we have? So straight leg raise, if you want to lay down. So if a pure straight leg raise would be the affected side. So if she has issues on her left leg, I would raise the left leg for a straight leg raise. Let me know if you have any symptoms down your leg. And you can also dorsiflex. That tightens, you're literally stretching the nerve. If you think about this centrally, as the nerve roots come off the side, it's all connected into one. So as I'm pulling, I'm trying to stretch that nerve to cause the symptoms. And if you think about how the nerve roots come out on both sides, but they're connected centrally, that is where the contralateral leg or the cross leg straight leg raise comes into play. So if her symptoms are still on the left side, I'm actually going to raise the right, because if I'm pulling on the right and stretching it, it's all interconnected, it should flare up the right if it's positive. So if I bring the leg up, and again, you can dorsiflex the foot, that adds even extra more to it. Any symptoms down that leg? Okay, so that would be negative. But if it were positive, then we'd be recreating the symptoms that way. Does that make sense?
So you would, if the problem was on the left, she would have pain when you do the straight leg raise on both sides? She would have pain in the left leg?
She could. A positive straight leg raise would be down the symptoms. A cross leg straight leg test is you're doing the unaffected leg, but you feel the symptoms in the bad leg, the opposite one. Mm-hmm. So it's just because everything is interconnected centrally. So you're pulling it just enough that it's, and that I would say, and it's more of a severe case, because it's so flared that even pulling the other side is going to be enough. So I don't know that we have anything to measure, but for true limb length, so you feel the ASIS is the anterior superior iliac crest or spine, if you will, and you find the same point, and then you would measure median malleolus. And some people will say, oh, you measured, to the center, or just where you feel the end, just the inferior border. Whatever you do, obviously do it the same on both sides. So those are roughly your measurements, and so you can feel your anterior superior iliac spine. You can almost feel the edge of it there to the medial malleolus, and do that both sides. And again, most common, people are going to be slightly off. So if they're like a centimeter off, don't Don't let them go off the handle. Just explain that it's very common for people to have a limb length inequality. All right, so we're to the hip. So obviously you're watching them walk, watching your gait throughout. Go ahead and lay on your side for me. So I'll just stay here so you guys can see. So palpating the greater trochanter. Is that tender? Okay. For some people it might be, okay, but that's roughly where your trochanter is. Sorry, I'm gonna palpate your ischial. I mean, it's pretty much, if you sit, it's your butt bump, okay? Where you would, where your hamstrings are gonna insert on, that's your ischial. You have a bursa there too. So again, if somebody falls and lands right on it, they can flare that up quite a bit. So you palpate both of those, and again, palpating bilaterally, because this, don't be surprised if you start pressing on yours or somebody else's, it's gonna be tender. So make sure you're checking everything bilaterally. All right, so you can go ahead and lay on your back as far as you can, and when you're testing it, you want to make sure you go as far as you can. This would be forward flexion, okay? You can do, sometimes again, that same ASIS, you want to kind of make sure they're not rolling. You can bring them out for abduction, and then you can make sure you don't just bring them back for, you can't just say, okay, this is abduction. You need to go past to see what their motion is, okay? If you could just go AB and AD, that's kind of not doing the full amount of motion that you need, okay? And then for extension, you can have them roll on their side, you can have them supine, you can have them come to the edge of the bed, or while they're standing at some point, you have them extend. Do you have a preference of how you want them to do it for practical purposes?
No, I think for the practical, I'll walkie-talkie. It's okay to stand up if you want. If you're already on the bed and they're on their side, then it's fine to extend that way as well.
So go ahead and how you roll on your side again. Or actually just, sorry, go ahead and lay back for a second. We'll do favors first. So favor, remember, use the name to help explain it. It's the flexion, abduction, external extension. So I'm going to flex and abduct and externally. So I'm pretty much doing a figure of 4. And now this one, again, you need to kind of brace the opposite ASIS, and I'm going to press down. Any pain in your lower back? So this is checking for SI joint irritation, okay? And okay, now you can roll over. So the next one is looking at the iliotibial band. And remember, your iliotibial band is this wide band of tissue that crosses the knee and inserts inferior. So you have this wide band of tissue, and if it's tight, okay, go back to some physics here. If it's tight, it's going to be so tight that her leg's not even going to relax down to the table. So what you do is you need to go ahead and relax. Is you let them relax, and as I kind of relax the leg, it should fall back down to the table, because this is nice and loose. Imagine if this area right here were so tight, what would happen? It would still be up in the air. She wouldn't be able to lay it down. So that's your over for IT band tightness. So positive would be failure to relax to the table. Okay, does that make sense? And you have to check them both sides too. So everything we would be double checking both sides. So if it's too tight, it can't relax down towards the table. Right? Go ahead and just sit. Go ahead and slide to the end of the table. I think you guys can see better that way. So obviously you're looking for any obvious deformity as they're going through a range of motion. You can even watch. She almost, okay, so we did a J sign there for a second. So at the very end of extension, for a second, her patella almost kind of went lateral. That's that J sign that we were talking about. Okay. So what else? So your quadriceps tendon, your patella, your patellar tendon is going to be anterior here. The tibial tubercle is where that inserts. Your medial joint line. So if you come just medial, or if you follow her patella inferior, and you can feel where the tendon begins. If you go just medial to that, you can almost palpate, well, you can on her, the medial joint line. Some people you'll be able to find it a lot easier than others. But a lot of times when you do a knee injection, that's where you're going. just inferior to the patella, just medial to the patellar tendon, and that's where you would give an injection, because that's where you're in your medial joint line. And in through here, the nice thing is it's your femoral condyle, so there's kind of a little space there where you can palpate the medial joint line, but then you kind of have to follow that around. Does that tender at all? Okay. And again, that might be another tender spot, so make sure you're doing that bilateral. Is lateral? Okay. That comes later. All right, I'll go in order. Medial collateral ligament. When you were, go ahead and just relax now. So your medial collateral ligaments are going to go along the medial aspect and through here. So sometimes it's hard to differentiate between, okay, am I along the MCL or is it true medial joint line? We'll just go inferior and superior to your joint line if you're not sure. If they're still tender on the ligament, just inferior and just superior, then you're thinking more ligament issue rather than just joint line. And you've got your semimembranosus and then your all your pes. So semimembranosus, all these adductors, and your pes are all the adductors that are going to help bring your leg back medial, and they're going to insert right in through here where your wonderful incision is. So you can even palpate on some people. I can feel hers, the pes and bursa. So remember, it's those three, the little goose foot insert into the tibia right there. So that pes is to protect that. And that's where sometimes people will, have issues because they've been limping or they have chronic arthritis and they're limping, and they're like, oh, coming in for another cortisone injection, but the knee feels, but the pain's a little bit different. Palpate their pes and see and it's a fun one to do too, because when you inject it, it kind of swells up like a little golf ball right there. Kind of fun. Anyways, okay. So the popliteal fossa is just posterior. You've got your biceps femoris. Again, there are a lot of times. You've got all the different large quad muscles and all that up here. You've got your large muscles in the back, and you can feel the split of those. The hamstrings posterior, you feel that. And your LCL is lateral. So again, same thing. You've got your lateral, your LCL. Make sure you're palpating both superior and inferior to the joint line. And then you've also got the lateral joint line. So same idea, you go inferior to the patella. Now you're just lateral to that. I can even see where her portal scar was. And then you're going to go lateral. And sometimes these you have to palpate with some good pressure there. Fibular head. Remember we talked about even ankle injuries. You want to palpate to the fibular head because that can be a source of where the stress or the force will exit. So you're kind of palpating right around in here for that fibular head. And these are pretty obvious. Again, you do extension usually to 0. Some people can get a little bit of height for extension. You're probably not going to on that. And again, sometimes people will argue that there is some rotation to the knee. For example, if you tear your ACL, you can see evidence on MRI where there are what's called kissing contusions. It's where the femur and the tibia come in contact, and where they come in contact, they get these bone bruises, and they're not where they would line up normally. So that tells us that during that injury, there was some rotation that occurred. Yes. All the wonderful knee tests. So go ahead and slide up to the top for me. And you're never going to forget what valgus and varus is, right? Okay. So whenever, you can go ahead and relax. Do you want to shoot or anything, or you do? Okay. So whenever you are testing a ligament, you have to make sure that your patient is relaxed, okay? If they're firing their muscles, just kind of tap on them or get them to relax, and that can help. You also want them in slight flexion for a lot of these. And so again, you can use the side of the bed sometimes. You can kind of do the elbow trick and do something like that, or you'll figure out different ways, because some people are like, oh, my hands are too small, I can't do a lockman. No, figure out a way you can do it, okay? So you have your varus and your valgus stress. That's my what? I'm not looking for the pig. That's the valgus. Now if I want to switch, and you can either switch your hands underneath this way for a varus, or you can kind of do this if they're comfortable enough, and you switch it that way. For a varus, okay? See that? And again, you're gonna see different ways to do it. But the main thing that you are doing is making sure you're stressing the joint, which way you're stressing for it. I'm going medially, and I'm doing a valgus stress, or I'm doing my there goes the pig, and I am going the bow-legged, checking for my lateral collateral. Okay, do you see the difference? So I am listening to my patient to hear if they're having pain, but for these ligament tests, I am also looking for widening of the joint, and I'm comparing. And if that means I have to go back and forth multiple times to get a good feel, that's what I'm doing, okay? I will tell you this, if you have a high suspicion of an MCL tear, and it's a higher grade, you can just kind of externally rotate the foot, and that is enough to cause pain. So sometimes if they're in a lot of pain and you have a high suspicion, I would do that first, kind of like you were saying, before you go and you start pulling on their knee, just try that first. And again, you're doing the good leg first, so you have a feel of what their normal is, and you're kind of letting your patient know what you're doing, okay? In position, you will notice a slight step off, but what you do is you kind of get their foot here, and I'm going to have to sit on the foot, and I am pressing posterior. And now she's moving because I have to put a good amount of force to make sure that the PCL is going to tighten, and it's going to prevent me from pressing her tibia past where it's connected to the femur. Does that make sense? So I'm making sure that she's not budging past that, and you can do both, check both sides to make sure. But again, if it's there, then sometimes you'll even just with her resting kind of see a little step off, and that's more common if you see a PCL if you fall and land on something. So imagine if I fell and I hit, I landed on a ball or something, and the ball knocks my tibia posterior, so that's going to take out my PCL there. So Lockman, well, before I do that, an anterior drawer is the opposite. So I'm checking for my ACL, and you can, sometimes people will say you want your thumbs right here so you can kind of keep an eye, and you can even feel if your thumbs lift off, but I can see she's not going anywhere. But again, notice, I'm shaking her leg. I'm pulling with a pretty good amount. So now go ahead and relax both legs down. So now, those are all pretty, I don't know, maybe a little bit easier to do, so to speak. Your Lockman and your McMurrays are going to be the ones that you need to spend a lot more time on. I think those are always the hardest for people to do. But if you think about, after all that, so what you have to do is kind of relax the arm or the leg, shake it a little bit, and again, if your quads are firing, just kind of tap on it a little bit, and then you can either like let the leg hang off a little bit or keep it on and just hold the weight of the leg up a little bit because you want to be in a little bit of flexion here. And so with my left hand, I'm pretty much just bracing her femur. With my right hand is the one that is doing the movement, okay? So you can almost see how it tightens, and there's no way it's going past that point. Can you guys see? You guys see that? So this hand, so she's in a little bit of flexion, she's nice and relaxed. The other thing is when you know someone's relaxed, they're gonna fall into external rotation. So make sure they're relaxed. I am bracing with my left hand. I am pulling anterior with my right hand. And there, boom, is a clear stop right there. It's not moving, okay? Leg relax a little bit. Now I'm switching, so this hand is now gonna hold it steady in place, and this hand is gonna be doing the anterior translation. So this one I'm blocking, I'm doing this, okay? Just nice and relaxed, and I'm blocking in. Okay? Is that there's some type of your inflection coming to an extension and kind of a rotation to it. Your left hand, or whatever hand is closer to the head here, I want my fingers along the medial and lateral joint line. This test is a provocative test, meaning if they have pain, I'm going to be doing further imaging, but it's also, you can sometimes palpate a click if it's the meniscus tear moving as you're going through your range of motion, because you're essentially pinching that meniscus as you're going through the range of motion. So sometimes you have to move them back and forth a little bit to make sure you're in the right spot. And then you bring them clear up, and then you can kind of rotate this hand. See how I'm rotating? And I'm rotating as I'm coming into extension. And then you can do the same, this hand is kind of bracing and feeling it and helping to apply that type of movement.
So you're doing, on the external rotation of the foot, you're applying valgus stress as you extend, or are you doing any kind of varus valgus stress, or you're just simply rotating the foot?
Majority, it's just simply rotating, but technically, immediately you would, you would do varus external. But, so you kind of doing that, and then that. You see the motions? So they're kind of awkward, but. Because I'm trying to, if you imagine, I'm kind of pinching it and pinching it. Does that make sense? Balloon. So what you can do is, if you think, imagine I had a water balloon on the table, and if I press the water balloon down here, whoop, it's going to go up, right? It's the same idea, because that's essentially what your joint capsule is a big fluid-filled bubble. And so what I'm doing is you kind of almost milk the fluid down, because it likes to collect suprapatellar, and if I'm feeling for that push of fluid against my fingers. So as I compress down with my left hand, I'm feeling for that push of fluid on my right hand. Which you don't have it. I mean, everybody should have a little bit of fluid in their joint. That's good. So the other one is the ballottement. Is now, okay, imagine I have my water balloon and I've got like a rock sitting on top of it or attached to the top of it. But my balloon is still deflated, okay? So if I've got it on the table and my balloon's deflated, my rock is sitting right on top of the table. So if I push on it, nothing happens, right? Because the rock is sitting on the table. I put a little bit of water in, same thing. My rock is still against the table, I push, nothing happens. I put a lot of water in it, now my patella, or my stone, if you will, kind of floats up a little bit. So when I push, I can push it back down to the table, and as I do that, kind of clunks against the table. That's what that's what you're looking for here, except for that little rock is your patella. So if there's so much fluid in there that the patella is kind of floating in that fluid, and so when I press down, it's now coming back into contact with that femoral groove. So you're kind of compressing the fluid down and then pressing to feel, but her patella is already in contact, so I don't feel that clump. And her arch to see if she does have an arch, or to see if she has flat or because you almost have a little bit bigger arch on your left. Okay, so you can go ahead and have a seat. So at some point you need to have them stand up. Don't forget that. A lot of times people get into the feet and they want to sit and you want to look, make sure you check, because that's supporting everything else. Make sure they have good support in their feet and their arches. More medial structures, your medial malleolus. Remember I was talking about remembering your soft tissue structures. So you have your medial malleolus, you have your posterior tibialis tendon, which kind of wraps just posterior to that. You have your deltoids, and then you go lateral, you've got your lateral malleolus. The perineals on the lateral side kind of wrap around and insert on the base of the fifth metatarsal. And I say that because a lot of times people will come in with pain and they think they fractured their fifth metatarsal or even have a stress fracture of their fifth metatarsal. And they're not so much tender there, they're tender just proximal to that. It's because of a perineal tendonitis issue. So that's a big one that is often missed. They're diagnosed with some type of fifth metatarsal whatever until they get to us and we realize that no, it's actually their perineal tendon that is the issue. Oh, your anterior ankle joint, your Achilles tendon, obviously, you've got your Achilles back there that you can palpate. Remember last week we talked about tendinosis, where it's not just tendonitis, but the tendon itself changes. You can get, and it's a thickening that you'll notice, you can get patellar tendinosis, you can also get Achilles. That's another favorite tendinosis place is the Achilles. So you can feel right to left, and then they're at risk of rupture if that happens. Talk about the plantar fasciitis. It's inserting right in through here. So a lot of times they're tender throughout the soft arch, but where it inserts onto their heel, right in through that, that's an extremely tender spot for plantar fasciitis. So then you go through your tarsals, you go through your mid. Well, you want to make sure you're palpating your midfoot and your cuneiforms and then your metatarsals, and then down into your tarsal bones as well. Goes up to dorsiflex and then point them down. Plantar flexion, is that how they're labeled there? I probably didn't remember. Yeah, no, okay. And then you can have inversion, eversion. So make sure you're locked. Make sure you're blocking your joint. Point your toes together. There you go, and then point them out. There you go. Good. So inversion, eversion. So the special test for the Thompson, go ahead and flip on your belly. You can, you're assessing for Achilles, and so what, can you guys see? If I squeeze her soft tissue, her calves, her gastrocs, she is going to plantar flex, because this is, you remember, muscles. If you shorten a muscle, it's going to cause movements. By squeezing, I'm essentially shortening the muscle, and we should see that plantar flexion. You guys see that? If her foot does not move, that's a very high risk for Achilles rupture. All right, good. Barometer. Remember, this is a compression, a medial to lateral compression. So when they're squeezing into their teeny tiny shoes, higher risk. So that's why one of the treatments is you want a wide shoe. So in order to do this, I'm going to be palpating, kind of, remember, it's most common in between the third and fourth metatarsals. So your metatarsals, they're easy to find inferior. You can kind of palpate them there. And then so what I'm doing is I get my fingers kind of in place, I'm compressing, and now I'm kind of palpating and I'm kind of moving around, and I'm feeling for any click or pop because of that enlarged sheath around the nerve. And that would be positive. If I felt like a click, then that would be positive for the mortise neuroma. The calcaneus squeeze test, this is looking for a stress fracture. If someone falls or jumps and lands on their heels from a height, you always want to look for a fracture, and it's pretty much, I'm just squeezing. And sometimes you have to squeeze a good amount. So some people will kind of wrap their hands together and squeeze this way, but pretty much you're just compressing that medial lateral squeeze of the calcaneus. And positive would be for calcaneus stress test or injuries. So you're going to do special views, or if need be, go into an MRI. Anterior drawer, it's the same idea as with the knee. This hand is going to hold her tibia fibula in place, and my right, I'm holding her calcaneus, and then I'm going to try to do that anterior translation, okay? Did you ever injure your ankles?
I just have really bad ankles.
And so she might have a little bit of motion, so you can almost see how that comes forward just a little. You can probably see how this comes more prominent. Not too bad.